What's the difference between AVRT and AVNRT? They're both dysrhythmias. They're both supraventricular tachycardias. In fact, between the two of them, they'll make up most of the SVT that you'll ever see. And they're both reentry rhythms. They both involve an impulse that gets stuck in a loop that keeps refeeding the electrical system. So what's the difference? The difference lies in the N in AVNRT, atrioventricular nodal tachycardia. Atrioventricular nodal reentry tachycardia is its own distinct pathology not related to WPW or Wolff-Parkinson-White syndrome. AVNRT, or atrioventricular nodal reentry tachycardia, is a little extra loop of circuitry on or around the AV node, and it's made up of the same tissue as the AV node, calcium channels, and impulses can get stuck in that loop and refeed the electrical system, causing a supraventricular tachycardia. AVRT, atrioventricular reentry tachycardia, is related to Wolff-Parkinson-White syndrome, or WPW. In normal physiology, the only way an impulse can get from the atria to the ventricles is through the AV node. But in WPW, there's an extra circuit that bypasses the AV node and connects the atria and the ventricles directly. And that extra circuit is not made up of calcium channels. It isn't a slow channel, it's a fast channel. And in AVRT, that extra circuit conducts electricity in one of two ways, anterograde or retrograde. In anterograde, an impulse travels its normal pathway. It's generated by the SA node. It comes down the internodal pathway as it goes through the AV node, but that extra circuit refeeds it back up to the bundle of His. In retrograde, that impulse that's generated by the SA node travels down that extra circuit and completely bypasses the AV node. That retrograde conduction is known as antidromic AVRT. And that anterograde conduction is known as orthodromic AVRT, and orthodromic AVRT is the dominant SVT that you'll see in WPW. In fact, it makes up 1/4 to 1/3 of all SVTs that you'll see in the field, with the rest of those SVTs being mostly AVNRT. That orthodromic AVRT usually kicks in when a low-occurring PAC or a high-occurring PVC generates an impulse that gets caught up in that loop. Now, you probably won't be able to tell the difference between orthodromic AVRT and AVNRT on an ECG, and it really doesn't matter if you can or not. But you can tell the difference between orthodromic AVRT and antidromic AVRT because orthodromic AVRT is a narrow complex and antidromic AVRT is a wide complex. All of these dysrhythmias can be converted by adenosine, although I would treat any wide complex tachycardia under a wide complex tachycardia algorithm. Contrary to what you were taught in paramedic school, adenosine is safe for patients who have a history of WPW as long as they are not currently in an SVT with atrial fibrillation. Follow your local protocols. This is for educational purposes only and is not medical advice.